With the camera still looking at me here.
Good afternoon, everyone. We are so sorry for the technical difficulties that we're having. We did several practice drills, but it does not want to work from the computer that we were trying it on this time. So can everyone hear me okay at this point? Just shoot us a message if you don't mind in the chat function or in the questions field, a yes or a no.
Hi everyone, we think we figured it out, so please give us a thumbs up or yes, I can hear you if you can. And we'll get started as soon as we hear from you guys.
Oh, yay! Yes! Oh, fantastic. We are so sorry to keep everyone waiting. Thank you so much for being so patient and for sticking it out with us. We did several practice runs, but of course the computer that we're using right now is not as friendly as or kind as some of the other computers were to us. So thank you again for waiting. Good afternoon. We welcome you, and we hope that today we can start the lines of communication as to vision therapy's impact in early intervention. And as professionals and as parents, I'm sure many of us are already aware of some of the more obvious vision conditions, eye turns or low vision, visual acuity deficits. But we hope today to also make you aware of some of the more hidden disabilities, some of the much less assessed areas of visual processing that our office really specializes in and is very passionate about. So we want to encourage you too to ask as many questions as you have throughout the webinar, or you can hold the questions until the end. We'll be checking in to see, but certainly feel free to use the question or the chat function in the field. So in just sort of introducing the Center for Visual Management, we do provide early intervention services, and many people don't realize, but we do also help carry services through into CPSE. The continuation also goes on for district-referred CSE populations. So we do hold a contract with Putnam Northern Westchester BOCES, and many of our school districts will approve services continue through kindergarten on. And while you see here the list of conditions that we treat with our children or adults, it's important to say that sometimes children or patients come in and they present with very mild vision deficits, things that are very easily or quickly ameliorated. But then on the other end, we do see more significant vision impairments. And to say we are very comfortable working with birth through, senior years. We're happy to work with verbal as well as nonverbal individuals. We're very comfortable there. And so in introducing my colleague now, Dr. Calentarova, who does all of the assessments herself. Dr. Calentarova holds her doctorate from SUNY Optometry. She completed her program in 2016, all the while knowing that vision therapy was the subspecialty that she was most passionate about, and in particular early intervention, because as we see here, even small input from our end can really lead into more significant outcomes for the children. So it's very exciting work and we just love it. As far as introducing myself, I'm Barbara Kotsamanidis-Burg. I've spoken to many of you over the phone, and it's always nice to put faces to names, and I hope I get to meet everyone at a meet and greet or an event in the near future as well. So I have been a vision therapist for the last 19, 20 years or so, and am clearly still very passionate about it. About 8 years ago, I also decided I would take interest in research, so I do have some publications and experience there under my belt. My priority at this point in time is advocating and trying to ensure that children who require vision therapy or vision services are getting the help and the services that they need, regardless of what zip code they live in or a parent's socioeconomic status, regardless of what their insurance policy says they are entitled to or not entitled to. I feel these are services that children will benefit greatly from, and we need to put it into the hands of our community and help advocate for it. You may have not associated vision with autism or developmental delays in the past, or even sensory processing disorders, but you should. And I truly hope that this webinar will help make it clearer or help make sense of exactly that. What is the role of vision?
So to start, we wanted to do a little brief demonstration with you guys. If you could look around the room, take a few seconds, look around the room, and then close your eyes. Let's think about what other sense provides you with as much information as vision can. So let's think about it. You can open your eyes now and look at all the information you get when your eyes are open. What other sense can truly give you as much information as quickly as vision can? So vision is our dominant sense, and often it's taken for granted or overlooked when things are working normally. Our objective today is to engage a conversation between professionals and parents and helping to identify key behaviors or delays that are associated with visual dysfunction. We hope to make you aware that vision therapy can be a very powerful component in managing your children's development. So some facts about vision in children. 19 million children worldwide are living with a vision disorder. 1 in 20 children are at risk for permanent vision loss due to vision disorders like amblyopia. So that's about 1 child in every average sized classroom. 80% of vision disorders can be prevented or cured, such as amblyopia that we just mentioned before, as long as it's treated early enough. 1 in 3 American children have received eye care services before the age of 6. But how can we make these statistics a little friendlier, a little better? By ensuring we get eye examinations before the age of 2 or 3 is how we can lower these statistics and make them more modern world, as I can say. So what kind of eye examinations? We have a lot of parents come in and say, we ask them, have you had, as a child, haven't had an eye examination before? And they'll say, yeah, at the pediatrician's office, or they'll say they went to an ophthalmologist and they said everything was fine, but they still find that their kid is bumping and tripping and not seeing things, or something seems to be missing. So we have, we wanted to divide it so it's to show you that eye exams can be variable. So this traditional eye exam or traditional pediatric eye exam looks into the anatomy of the eyeball, making sure it's healthy, and visual acuity. Can that child see? When the children are very little, the 0 to 3 populations, we cannot always determine how much they can see, but we can say they can see, or we can determine that there's no significant refractive error. However, we cannot rely on traditional eye exam to truly diagnose visual dysfunction in this population. So we like to delve a little further. So the red on top, the 2 boxes, describes what is examined during a medical eye exam. And the green boxes is what we like to go into further in our sensory motor diagnostic evaluation. This is more geared towards developmental and educational models of optometry. So binocularity is the ability to use 2 eyes together. Are the eyes working as a team, or are they battling each other, or one is shutting the other one off because it's not giving us as good information? Ocular motor, which is tracking. Is the child able to make meaningful eye movements, purposeful eye movements to direct their vision to where their attention wants to be? Focusing and accommodation. Is the child able to change their focus from far to near and really clear whatever they're trying to see? Depth perception is the ability to see 3D vision, to determine distances. Visual fields is the ability to use all your vision 360 degrees. Is the child as aware of things above them as they are things below their visual axis or their visual field, the primary visual field? And perceptual vision is how vision is related to learning. So other things we look into is the ability to use vision to know your space around you. So we often ask, can the child use vision to determine where their body is in space and where an object is in space, like their favorite toy, or how far away is their favorite snack in space as it relates to their body? This level of visual function then provides information for proper motor planning, and the systems feed back off of each other. This is how we fine-tune and strengthen our visual motor integration, and the same applies to visual vestibular integration and visual auditory integration. When I was a student, I really appreciated when professors would make things simple and logical to understand, and I had a great professor who described vision as a system. She said if you give a system good input, the system can produce good output. So if we give a system noisy input, it's going to be noisy processing and noisy output. And this is what we often see. The list here that we showed you describes visual skills, but any deficit in any one of these skills will produce that noisy input. Then the child has a hard time processing what they're seeing, and then we get that noisy output, or clumsiness, or difficulty processing, difficulty with sensory integration, spatial organization. And the big hit here is developmental delays that are often unexplained or have no relation to a specific diagnosis. So what we're looking at here is different ways we can see 20/20. So we could see 20/20 and double, which is right over here. We could be seeing 20/20 and be compressed or tunneled, which is over here. And we can be seeing 20/20 with variable deficiencies in color vision. So it's not only important if the child is seeing 20/20, that's just one little part of the visual big picture.
So how exactly are our early intervention children seeing? We recently sat down and assessed 41 EI cases that we've seen over the last 2 years. And if you look at the sort of copper orange color area, the most prevalent visual processing dysfunction that we are seeing in the birth to 3 happens to be visual field limitations and visual spatial deficits. And so what exactly does that mean? And how do we know to look for it? How can we assess it? Well, it means that the child's perception of their space world is challenged or impacted. It could become apparent when he or she appears clumsy or is bumping into walls or corners of the room. They may seem frightened by their space, like stairs. Even in something as simple as a sidewalk curb can be a challenge for them. Interestingly, you might also see it in their posture or in their gait. So conditions like toe walking or pigeon toeing, for example, can often be a result of how vision influences posture or how it influences your motor system. In one case that we'd like to highlight at this moment, in one young boy who was brought to us close to the age of 3 years old. He came in, and watching him in our office over the course of the 90-minute evaluation was really just sort of painful. He was inattentive, he was extremely hyperactive, and frankly, he was walking into walls and hitting his head on what I would tell you was like every 5th step. And in 20 years, this one stands out to me the most. Safety concern was mom's #1 priority. And in this case, there were no medical diagnoses. There really wasn't a vision diagnosis per se. The child saw 20/20, did not have an evident eye turn or anything like that, but his visual spatial system, he definitely lacked depth perception. And so we recommended vision therapy, and lo and behold, it was really just 11 therapy sessions that we conducted with him once a week, 30 minutes, before we were able to graduate him. We focused mainly on depth perception, and by doing that, stimulated the process for attention and focusing all the while. And so, though he saw 20/20 and his eye movements were okay, depth perception was really the larger deficit in this case. He had received several traditional eye exams. However, without assessing or identifying the areas that Dr. Calentarova just outlined a short while ago, the opportunity to receive the appropriate services and the appropriate care might have not been there for this child if it had not been for early intervention. As you can see as well, this dark blue area here is the second most prevalent visual delays that we're seeing here at the center, and that's ocular motor dysfunction.
So ocular motor dysfunction is, simply put, poor control over eye movements. This gives us information regarding the who, what, when, where, and why of vision. So to tie back to our demonstration from the start of our webinar, vision, attention, specific eye movement, all those three combined give us information on who's in the room, what are they doing, when something happens, and where a person or an object is in the moment and why they're there. So comprehending and understanding our environment, what's going on, this is what we need. We need these eye movements to properly assess and gather this information. A child that has difficulty looking at a target or moving his or her eyes purposely to a task. For example, for this population, it might be very difficult for a child to search for a toy when it's laid out among like 3 or 4 other ones, or being able to move their eyes from one target to another when you're playing with battles or anything like that, whether it's left to right, above or below, or further and closer. All different axes of vision that we are constantly dynamically using throughout our day. And lastly, being able to track an object for safety purposes, like if something's coming at the child, they might be very delayed in reacting to it. So how did this become apparent? During our examinations and during taking history of what's going on at home, the child may not respond or be very slow to respond, to changes in the room, like someone is coming or going, or there's a dog that just ran across the room, or a ball drops or is rolling to the child, and they seem very unaware or almost zoned out to what's happening. A child might not have any interest in playing with certain toys, especially ones that involve a lot of motion, and they don't take interest in things like popping bubbles. They might avoid or get very frustrated when doing puzzles or picture-finding books because it doesn't interest them. It's very difficult for their eyes to scan and move and search. They also might be very slow to swat or seem startled when something is coming at them into central field, like let's say a balloon, you'll pass it along and they'll be unaware, and right as it hits central, right in front of them, they become startled by it. Or they'll swat it away as if to protect themselves because they don't have enough control over their eye movements to think, okay, this is in front of me, this is like 10 inches, I can grab it here, this is 5 inches. For them, it's really far away, and all of a sudden it's right up in their face, and that's scary. Later on, this development of specific eye movements will also determine visual motor areas, like recreating shapes or writing the alphabet. And then when we go past that and they keep developing and growing, it could turn into how easily they can read or learn in a relaxed way, or even more mature, how well of a driver are they, and so on. But we'll discuss some adult consequences of difficulty with vision later on in the presentation.
Another case in point, so a real life implication, a real life story of what ocular motor dysfunction looks like in our birth to 3 population. And there probably was not a dry eye in the room when this child really started to develop, and we witnessed her achievements here in office. Child was brought to us at 26 months of age, so she was just over 2 years old. She was still unable to sit up on her own unassisted, leaned very heavily to her left side, had been receiving intensive services since birth. The birth issue and the medical diagnosis is that she did experience a stroke at 6 days old, and following that, an open heart surgery as well. Visually, when she came to us at 26 months old, she presented with a very rapid, a very intense nystagmus. And this is when the eyes involuntarily sweep back and forth, back and forth, back and forth without stop. She also presented with obvious fine and gross motor delays. Our recommendations at that time were vision therapy twice per week to work on the ocular motor dysfunction. And within weeks, we were able to stabilize the intensity of that nystagmus. There's no cure for nystagmus, but you can definitely dampen and help the person gain control of their eye movements. Within weeks, she not only began looking at her world and making more sense of it, but vision began integrating and working with other sensory modalities. Within a few short weeks, she had begun sitting up on her own unassisted, but was also beginning to take steps. And so now vision was a bit more stable and was integrating with the vestibular system. Within, it was about 6 months of her being in the vision therapy program, she was walking from one end of the office to the other. And our office is about 2,000 square feet. So to have you visualize, she would walk from our waiting area back into our therapy space, which is probably about 60 steps for a little toddler. So very rapid improvement and really a very significant impact just by working the ocular motor system.
Fantastic, and that's what we've been seeing. So for generations, we've heard many arguments that these disorders cannot be treated. We've even had, unfortunately, patients come in saying, you know, my child has been receiving eye care every year. We take him to the eye doctor every year, and parents feel like they're doing everything they can, which to their knowledge they are. And then they come in and we diagnose them with something in our sensory motor battery and explain that this is how vision relates to the difficulties that you're seeing. Ophthalmologists mostly have a medical. I want to just bring this to light because this is a lot of what we've been hearing from parents and to give an understanding of why you're hearing one thing in one place and another in another place. So ophthalmologists are great and they concentrate on the medical model. So is the eyeball healthy and can the child see yes or no? But they don't go into can they track, and then can they use the eyes together? And this is all part of visual function. It's just not in their training. So we've often heard that they'll tell parents, you know, don't even consider vision therapy. It's not going to work, or it's too late, or it's a myth. And we want to just make sure that we can educate everyone that it's not. It's never too late, actually. We can, therapy can work to rehab and train any system at any age, just as any other therapies can. So then no one is ever too young or too old to benefit from vision therapy or any other therapy. Through our experience, we've seen that the earlier we start, the easier it is to train visual skills because they haven't developed compensatory behaviors or habits, haven't been embedded yet. So this was our motivating factor. So why start when a child is 5 years old or 7-year-old if we can start earlier? And what we have found through our experience is that the earlier we start, the better, because the whole trajectory of the child's life can be changed if and when we get a visual impaired child the services they need as soon as possible. So I wanted to kind of demonstrate that with the graph here, that the earlier we start, even if we're making small changes, the trajectory as they grow is very impactful, and it gives them a whole different experience of their visual world and visual function through school, through young adulthood, through adulthood, and so forth. So visual skills in early childhood development, these are fundamental visual skills that are learned within the first few months and are more strengthened and solidified as the child ages. So fixation is the first and fundamental, most fundamental. It's just simply the ability for each eye to hold steady gaze on an object and to keep clear vision the whole time. So this is the ability to look with stability at something. And the first experience we have of this with a child is eye contact with mom and dad. When the baby's super young and the first few weeks of life, they're constantly looking around, and then we get glimpses of holding it for 10 seconds. Tracking is the next one. This is the ability that we spoke about before to follow a target depending on the speed in all directions and with accuracy. So another case we wanted to talk about today is a 6-month-old infant that came in, and at that time he was only reaching his 2-month milestone. When we implemented vision therapy twice a week for half an hour, 2 of the most profound improvements were made. Days that we definitely will never forget, and these were incredible moments. He was finally able to sustain eye contact with us and with mom and dad and caregivers and track his toys. This seems such a small thing, but in their visual development, this is finally the first skill that has solidified, and all other skills can now build upon it. So another skill that we look at is called convergence and divergence. That's simply the ability to move your eyes in and out, depending on how far or close something is. And we use this skill to give us information regarding depth perception. Accuracy is very important here as well. Saccade is the ability to look with the eyes and then attention from one target to another. This is used in scanning our environment to make a mental map. And then later on, the child uses this skill significantly during reading. So much like the case we just mentioned, we hope or expect these skills like eye contact to develop naturally, but sometimes they don't or they won't, and we need a little help to get them going, and a little help goes a long way, again, the earlier that we start. So here I wanted to discuss something called ambient and central vision. So ambient vision is not as popular or talked about as central vision, but it's a major player. 90% of our eyeball, anatomy-wise, is actually dedicated to this type of vision. And this is the where system we use to filter out what comes into our vision. So this, another way to put it, is our ability to quickly process what comes into our peripheral vision and attention. And then we delegate what's important to us to our central vision and attention, and all else to uninterrupted background noise. So when we're unable to do this, we often see that a child is scattered. Like any little distraction it becomes a big deal, or becomes overwhelmed with an environment and can't handle busy environments, new people tend to frighten the child because they don't have this filter system to be able to shift their attention where they need. So everything is bombarding their central vision, central attention, as if it's all equally important, which it's not. Children's ambient vision system is responsible for navigating their environment, having a sense of where they are in space and the space world as it relates to them. It encompasses the integration of other senses, so sounds, smells, to determine if the environment is safe or dangerous. So when this doesn't work well, it's very frightening. Once we are able to do this, a child can free up brain energy to develop social skills, communication, executive function, and they no longer have to use all their energy to just figure out what's going on, where am I, who's this, and so on and so forth. So a big tool that we use here are Prism Lenses, and there's a few different ways you can use Prism Lenses: corrective prism, therapeutic prism, and cosmetic prism. So corrective prism is basically prism that you put in front of the child's face to eliminate any double vision. However, it just works to do that, eliminate double vision. It doesn't truly train the eyes to work together as a team. Cosmetic prism is put on so that when you look at a child, you don't see an eye turn, but it does nothing for the actual visual function. It actually makes it worse by just separating the eyes and excluding them from working with each other even more. Then there's therapeutic prism, and this is prism of equal strength in each eye, put in the same direction in front of each eye, that promotes eye teaming, that promotes visual function. And this is used short term until visual skills have been developed through therapy, and then we no longer need that prism. So after conducting our evaluation and determining whether corrective or therapeutic prisms are beneficial, we talk about vision therapy.
If I can jump in here for a quick minute again and just again offer a real life example of the impact that our prisms have. In a similar circumstance as earlier, we were presented with a 2-year-old child, again, very rapid, very intense nystagmus, those involuntary side-to-side eye movements, as well as peripheral side viewing, which I know by our attendees here, a lot of our coordinators are working with children and have census children, and that's, again, one of the larger concerns. We do find peripheral side viewing to be secondary to double vision, and it's sort of a solution in blocking it off. Well, this child in particular could not track at all across into her right visual field. So imagine as you're sitting looking ahead now, you're only aware of what's in front of you or what's to your left. There was complete right side neglect, and that was the result of a brain bleed that she experienced at 1 week old. She had a complete loss of vision, which fortunately had been regained for her at about 3 months old. But from the very second that we placed Prism lenses in front of her eyes, she began to track across into her right visual field. And so as quickly as an adult can put on eyeglasses and see clear in the morning, was as quickly and can be as quickly as you will see the impact of the therapeutic prisms that we use here in the office. Of course, we went on to recommend therapy for this child as well. Absolutely with what we saw, we knew she was a great candidate, recommended twice per week, 30-minute sessions. And again, some of the highlights that came from her therapy, and I remember mom's goals very specifically, was that she'd be able to go on and hold her head up herself, which she was able to. And it was an extremely fun day in the office when she started imitating just different clap patterns that we were guiding her through. So her whole attention profile, the eye movements, her awareness of the world changed. And it was as simple as applying a pair of therapeutic prisms in front of her eyes and integrating it into her prescription.
So let's talk about vision therapy and what vision therapy does for us. So sometimes we have parents come in and saying, well, if the glasses are working, do we really need a therapy? It is a commitment, that's for sure. So what we like to say is, and we like to explain, is that the lenses are working as long as they're on the child's face, but the more meaningful, and it's a crutch, the more meaningful treatment here is vision therapy, is the ability to train the brain to better control the eyes, to use the eyes together as a team. So our goal is to enhance the individual's way of perceiving their world and then transfer these visual skills into real life. So a therapy approach, no different than occupational or physical therapy, can help raise the child's performance. Whereas sometimes we have parents ask us, we are doing patching, is patching enough? What's the difference? Patching is good to make the weaker eye stronger. But once we have that, we now have two strong eyes that haven't had any communication with each other and are not used to working with each other. Now we have to make them work together. And this is how we get optimal visual performance. So another question we get is, where does surgery come in? Is surgery necessary? We say surgery has its place, especially if there's a significant eye turn. However, we recommend starting vision therapy first to just get a better control over the eyes and to understand even through surgery, there's no exact way to know how much we're cutting and snipping. It's an estimate. So when we have better control, we have a more accurate sense of how much we really need to cut or snip to get the eyes aligned. And even after surgery, we strongly educate the parents. Even after surgery, now the eyeballs are in a different place and the brain has to learn how to use these eyeballs in their position now in order to lock it in and not have the eye turn the other way or come back. So vision therapy is needed for that. It provides a nice block of fusion and a good, a strong team when we get the two eyes to work together. So what activities do we like to do? We like to do activities that are dynamic, that are easy to do at home, that can be incorporated in everyday play. And we can give you some examples now even. So when we go to the park, me and Barbara are both mothers, and we're constantly doing vision therapy at home, you know, as I'm sure all professionals do. So when we go to the park, one of the things I love to do is put a toddler on the swings and swing them, but it's not passive, it's a very active activity. I'll say, you know, this is your right foot and I'll lift it. This is your left foot and I'll lift it as they're coming to me, and then I'll have them say, tap my left hand, tap my right hand, and they'll do it. So they're learning left and right, and they're understanding their vision and their body and what's moving and what means what. Or tapping a toy in space in different areas. I want to turn on the camera so you guys can see me for a second. Let's see. Okay. So I'm going to demonstrate again. So when they're on the swings, I'll just say like tap here, depending on one foot. Or if they're swinging and it's a little bit of an older child, I'll even do high five. I want a high five here. I want a high five here. I want a high five here. So every time they're coming to me, they have to anticipate and plan a body movement, but they have to use their vision there as well. Feeding, it's airplane with the spoon. You got to work a little before you get that food in your mouth as a reward. So that's tracking as we're bringing it closer to their face. That's convergence and divergence. Or showing them a picture find book while they're eating is great motivation because they have to slowly work on their tracking and their eating, so they're a little bit distracted. When we're playing indoors, blowing bubbles from behind the child, so they have to become visually aware that the bubbles are coming from here, or are they coming from here, or are they coming from above. Or playing finger taps, so like have a puppet and they have to touch it. Oh, it jumped over there. Oh, it jumped over here. So really simple things that we can do, and we love to use in office. I think our favorite toys are slinkies, balloons, bubbles. We use some like optometric tools, of course, like filters and things like that, but it's fun and very age appropriate. And when vision is trained, it becomes more automatic, and we see progression replace classical and other therapies that they've been doing. So we are very good at talking with other therapists or even communicating through parents saying, this is something that, what's their goal for OT right now? What's their goal for PT right now? And then we'll think of like the visual component that could be hindering them in that goal, and we'll address it. And we'll see the progression rapidly, which is great because again, one child, we're not just treating eyeballs, it's a whole body approach. So everything is very integrated. Okay, so as our mentor, Dr. Kaplan, used to say, behavior is a solution to a problem, and exposure is the key. So behaviors, what kind of behaviors are we talking about? So things to look out for: avoidance of near point tasks, or being very hyperactive. Child can't sit still because this is a solution to difficulty sensing the space around us. Or peripheral side viewing. They're looking through the corners of their eyes versus straight on, and this is to eliminate double vision. Or they're toe walking, and this is a solution to seeking input of depth perception and spatial awareness. Inability to sustain eye teaming results in avoidance of near point tasks. So if they have a difficult time using their eyes together, they're not going to want to do it for anything, especially up close, because their eyes have to converge and turn in, and they'll probably be fidgeting in their seat and do anything to avoid it for the last 5 seconds, and that's it. The exposure is the key. We're training the brain to better control the eyes, getting neurons to fire when showing a child to look from one target to another is a tremendous, tremendous task. It seems very simple, but again, this goes back to fundamental eye movement. If it's fundamental, it has to be fine-tuned to a very, very, very large degree in order to be used well. This connection is built through exposure. So just going from one target to another, even if the child is not moving their eyes, those neurons are firing, and this is exposure, 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 and this is how we build on these skills. So some of the diagnoses that we've seen in our early intervention population are cerebral palsy, infantile spasms, epilepsy, albinism, stroke, head trauma, etc. It doesn't have to be solely a visual problem. Vision deficits accompany all ranges of neurological disorders or disturbances.
So what exactly as a community are we looking at if our children were to continue not receiving vision services for vision impairment? We're basically looking at a population or a community with individuals who are 3 times more likely to be unemployed. These figures here are provided to us by the World Health Organization. 3 times more likely to be involved in a driving accident. 3 times more likely to suffer from depression and anxiety disorders, twice as likely to have falls. And so in sort of bringing back my priority, as I mentioned earlier in the webinar, is a call to action. So basically that we start to assess the types of eye exams that are being provided to children primarily in their most formative years, birth to 3, birth to 5, the school-aged years, identifying the needs and the gaps. And so, you know, it breaks our heart when we are speaking with a mother who has a child in the 8th grade, but whose child is still reading on a 1st grade reading level. And basically, year in and year out, her eyesight is fine, nothing else to do, where in fact, our evaluation had her jump to 6th grade reading level after 7 therapy sessions. So again, identifying these needs and these gaps is critical. And providing the best quality services that we possibly can, informing parents, informing professionals, and just continuously learning from one another and educating one another on what services are actually available. As we mentioned earlier too, as we work closely and we're looking more closely at the school-aged years and in working with our districts, we hope to continue educating our professionals that vision disturbances are twice as prevalent in ADHD populations and learning diagnosed children as well. So what do we as professionals look for? We're looking for inattention. Is the child having trouble paying attention? Are they easily distracted? Are they making careless mistakes? Is the body in constant motion? Are they fidgeting? Are they avoiding near-point work? Are they frequently interrupting others as a result of their inattention or their hyperactivity? So as we had mentioned earlier in the series, you might have not associated vision with autism or learning delays or sensory processing disorders, but we think really everyone should start to. Could we have helped the children avoid these deficits if only these problems had been addressed earlier in their development? And I think the answer to that is a clear yes. So I want to use this opportunity now to see if we have any questions from the attendees. Again, I want to thank everyone so much for bearing with us after the technical difficulties at the beginning. I see that everyone has remained on. We have new attendees who have joined us throughout the webinar as well. If there are any questions, please feel free to use the text box for the question function or the chat function. If there's any questions, we'll start to work through them. Otherwise, we do hope that you found today's presentation to be informative. We would be absolutely delighted to hear from everyone as soon as you'd like with any questions or any feedback that you have for us. You can always feel free to reach out to us. This is our contact information via email or phone call. If you're interested in just following the work that we do, jump on Facebook or Instagram, LinkedIn. We try to post informative articles, research, things that we can share with parents or professionals alike, videos of success stories, and etc. We also love to host meet and greets and really have as personable conversations as we can with the teams that we collaborate with. So if there's any interest there, please reach out, let us know. We'd love to meet you guys.
Thank you guys for participating. It was a pleasure, and we hope you learned a lot and this gave you some kind of guidance to how vision relates to development and what can be done for these young kiddos early on.
Okay, thanks again for joining. If you have any questions, do feel free to reach out. Otherwise, have a great day.
Bye, guys.
Bye.